A patient presents with severe physical escalation, absolute inability to bear weight on the left leg, 10 out of 10 resting ankle pain, and involuntary toe twitching. Alongside the localized joint pain, the patient develops a systemic symptom as their body temperature spikes to 100.4 degrees Fahrenheit. Rapid onset, localized pain, and a strong family history suggest a severe acute gout flare. A contradiction emerges in the lab work. The patient's serum uric acid level is 5.5 milligrams per deciliter, sitting comfortably within the normal range. A hot, restricted joint combined with a fever is a significant red flag for septic arthritis, a medical emergency requiring rapid intervention. Tracing the event chronologically reveals the specific stack of triggers that set this in motion. The physiological changes inside the bloodstream explain how a laboratory test can misrepresent the reality of an active immune attack. In emergency medicine, an isolated acute lab value can be deceptive if it is not contextualized within the entire physiological timeline. This 3D ankle model shows baseline vulnerability, mild arthritis, and an old avulsion injury. Dormant urate crystals were wedged into this compromised tissue. A trigger stack of physiological stressors, Hawaii heat, underhydration, and viral illness, progressively lowered the immune threshold. Systemic viral illness and severe sleep loss force the immune system into a state of hypervigilance. Patients often blame a high purine meal, but a single dinner rarely causes such a massive attack. Genetic predisposition and dehydration, intense physical load, and fasting are consistent amplifiers of crystal precipitation. As hydration levels fluctuate over weeks, the concentration of blood urate undergoes microscopic shifts that prime the joint for an attack. Once the trigger stack reaches critical mass, the localized immune system recognizes those dormant crystals as a biological threat. The flare represents the inevitable climax of a compounding cascade of systemic physiological stressors. On day 1, localized soreness on the outer ankle mimics a minor bump. By days 2 and 3, inflammation escalates into an acute ring of pain around the joint. This isn't crystals migrating, but an expanding inflammatory cascade sensitizing surrounding tissues. As the localized immune response intensifies, a substantial cytokine release forces a systemic leap, causing the patient to experience severe fatigue. This cytokine release also drives the body temperature up to the low-grade fever of 100.4 degrees. A hot, restricted joint paired with a fever necessitates a strict differential diagnosis to rule out septic arthritis. Clinicians ruled out infection based on normal white blood cell counts, the absence of skin wounds, and a lack of spreading redness. Prolonged icing contributed to the symptoms by forcing intense local vasoconstriction, which induced tissue stiffness and muscle spasms. Normal levels of EGFR, BUN, and creatinine confirmed standard kidney filtration, though they did not rule out genetic urate transport inefficiencies. An intense localized immune response can mimic a systemic bacterial infection, requiring multifactorial clinical criteria to differentiate the two. This two-compartment model explains normal blood uric acid during a flare. Lab tests only capture circulating urate, missing crystal deposits locked inside the synovial fluid. During a flare, increased kidney excretion and vascular changes temporarily dilute the remaining serum urate. Serum urate frequently decreases sharply during the most acute phase of an attack. Clinical guidelines advise practitioners to wait and repeat the uric acid test after the flare settles. A serum uric acid lab drawn during an active flare provides a distorted snapshot that is unreliable for ruling out gout. Once infection was ruled out, the patient was prescribed prednisone to halt the attack. Prednisone suppresses the cellular immune response, though it does not lower uric acid or dissolve existing crystals. As the inflammation subsided, the heat and throbbing stopped, but the pain transitioned into a mechanical, sprain-like sensation during weight-bearing. This ankle rendering highlights the peripheral nerves causing the patient's involuntary toe twitching. Swelling in the joint capsule physically impinges the superficial perineal and tibial nerves as they pass through the restricted space, triggering electrical shocks down to the toes. Normal levels of sodium, potassium, and calcium rule out a metabolic electrolyte imbalance as the cause of these sensations. The nerve irritation was compounded by a secondary shin cramp in the tibialis anterior muscle. This cramp was caused by prolonged immobility, and the altered gait required to use crutches. Severe localized inflammation creates a blast radius of secondary mechanical and neurological symptoms that are entirely downstream of the primary flare. The final diagnosis is a severe acute gouty arthritis flare occurring in a genetically susceptible and structurally vulnerable ankle. Dehydration, viral illness, and physiological exhaustion amplified the attack. This case highlights why clinical history and physical presentation must override an acute lab draw. After the immune attack is suppressed, residual tissue inflammation and nerve irritation require weeks of graded mechanical loading to fully resolve. Accurate diagnosis requires evaluating the entire physiological timeline, from the silent structural setup to the localized nerve impingement, rather than relying on a single laboratory number.